like to know who that announcer is, where he's sitting. Good morning, everyone. I'm Fred Osher, Director of Health Policy at the Council of State Governments Justice Center. It's terrific to be here in California. It is humbling. We have watched over the years the innovation of programming that you have sponsored, the efforts that have taught our country so much about how to respond to individuals with mental illness. I'm here to lay the groundwork for the next day and a half with some of the substantive material that you might feed into your discussions. But I'm also here to learn from all of you. And I hope that that's the theme that we hit on over and over. You have so much to share with each other and so much to learn from each other that may impact the phenomena that we're here to discuss. As Mike said, and thank you, Mr. Thompson, thank you, Supervisor Cox, thank you, Dr. Bender, for those introductory comments. We're here with the belief that if we put a structural and systematic and strategic plan together, that there will be fewer people with mental illnesses in our jails tomorrow than there are today. You heard about our tripartite national partners, but there are many more associations that have come together to inform and support the Stepping Up initiative, and in California as well. So many state associations that have shown great leadership in an effort to reduce the overrepresentation of people with mental illnesses in our criminal justice system. We've been referring to it, and people across the country have stepped up. The numbers change weekly as counties pass resolution. So important for the county leadership, commissioners in other states, supervisors here, to recognize and support a concerted, integrated effort across systems to deliver outcomes that ensure improved public safety and improved public health. And in California, I'm out of date already. The slide was a week ago, and I now know there's 26 counties that have passed resolutions. And thank you, those of you that have done so, and those of you that will do so. It really is something that tells your constituents this is an issue that you care about and that you believe there are solutions that can be generated through cross-collaborative activity. These Stepping Up counties, now it must be over 70% of California's population represented. At the Justice Center, the only point of this slide I want to point out to you is that we are in search of data to allow data-driven strategies to inform our policy and programs. And our constituents, elected state officials, count on that objective material to inform policies at the state level. I want to do three things in my short time with you today. I want to talk about how did we get here? What does this overrepresentation do to? Secondly, why is this so hard to fix? We've all been working at this issue, rowing generally in the same direction, but haven't seen the results that we all would like to. And lastly, how do we move forward with this information? How do we use this information, not just during this day and a half or year and a half, but in the years to come? This is an issue that is a part of our landscape that deserves the integrated, thoughtful responses that you'll create, but it isn't going to be solved overnight, and we're not naive about this. This is a marathon, not a sprint, and we join you in this. So, how did we get here? Here's a graph you've seen in various forms over time. We have about 7 million adults, and Stepping Up is about adults at this point in time under correctional supervision. That's the red line on top. The blue line in the middle are those adults that are under community supervision, probation or parole, and you know this issue well in California. My point in sort of highlighting that is individuals are in our communities at this point in time, and we have an opportunity to support strengths within them and to mitigate the likelihood of their return to prison or jail. The green line on the bottom is our jail population. It's about 750,000 people today are in our county jails. We are focused on the county because that's the portal of entry into our criminal justice system. And the jails are where the action is at. While our prisons have about 1.5 million people within them, and admit a little over 500,000 a year. As Dr. Bender highlighted, there are going to be over 11 million arrests brought to our county facilities. These individuals, unduplicated, are about 9 million strong, and within that group are about 2 million that meet conservative criteria for serious mental illness. And we're going to focus on serious mental illness in that these are individuals who, because of their disease, are disabled in ways that impair their function and make it difficult for them to navigate the day-to-day hurdles that we all sort of take for granted in our lives. And that's important for us to think about the type of supports that those individuals can use to realize their goals and aspirations. And while jail populations have declined in some counties, and it's the green bars that I'm pointing you to, the red bar is the percentage of increase or decrease in general, this has not been an even distribution. In a study we conducted at Rikers Island in New York City, where the commissioner at that time was quite proud of the fact that from 2005 to 2012, they had driven the average daily population from 13,500 to under 12,000. However, during that same time period, individuals, both in absolute number and relative terms, with mental illness increased. So while other people were finding alternatives to incarceration, individuals with mental illness seemed to be stuck. And we need to understand the reasons for that. This slide shows that 24 to 37% of the standing population with mental health needs. This overrepresentation is highlighted in a study that we conducted several years ago, 2 sites in Maryland, 3 in New York, in which over 6 months we asked 20,000 individuals to fill out a screening form and then followed up with assessment. And through that process, we learned at booking that 17% of individuals that in those 5 facilities showed up met our conservative criteria for a serious mental illness. And again, remember, this is a booking number, and for factors that I'll talk about in a moment, that number gets larger as people get concentrated within our jail and prison settings. Tease that number apart, 14.9% of men and a stunning 31% of women booked into those facilities met our serious mental illness criteria. And importantly, both men and women, 3/4 of those had a co-occurring substance use disorder, which might have explained why they were there, as they could have been arrested for sales or trafficking, but it certainly complicates their exit and successful reintegration to have 2 conditions that in synergy increase their functional impairment. It is not a random group in terms of ethnic and racial minorities, and I'm thankful to the Public Policy Institute of California for this slide, in which I just want to highlight that while African Americans in California comprise 6% of the population, in our jails it's 4 times that much. Our prisons, it's 4 times that much. And we need to understand both factors that contribute to that phenomena, but as importantly, apply the cultural competency skills necessary to ensure that all folks get what they need to support their strengths and address the concerns that they have and their ability to function within community. You know this story better than I, California's county jail population. And it's been a rocky course. This slide starts in 2010. Shortly thereafter, AB 109, we see an increase in the jail population. And then later on in 2014, largely as a result of Prop 47, we see a fall. And currently there are about 45,000 fewer inmates in our county jails in California than they were at their peak in the 1990s. So there's been an ebb and a flow to that. Does this reflect the same phenomena that I talked about in New York? We don't know. We hope to learn that through the course of our Stepping Up activity. I want to thank CPOC and the Behavioral Health Directors Association, California State Sheriff's Association for supporting the survey that Michael alluded to earlier. We got 124 responses from sheriffs, behavioral health directors, chief probation officers. It represented all 58 counties. I want to say, as I share and we share later some of the survey results, these are your perceptions of what's going on. That doesn't mean it's proof. It doesn't mean it's a data point we can hang our hat on, but your perceptions are valid, and we want to acknowledge them. One question that we asked: what is your impression of the number of people with mental illness in your county's jail over the past 5 years? The large blue wedge is it's gotten bigger. The green wedge, 13 of the counties, are a mix of respondents saying it's gotten bigger and it's about the same. 2 counties about the same. I won't ask you to raise your hand, but there's a county in here where the problem has actually seemed to get better. And when that county shares its secrets with us over the course of the next day and a half, I hope we'll find more of us in this category. But here we have 100% of the sheriffs that responded, people in charge and responsible for our county jails, sharing a sense that it has gotten bigger despite our efforts, despite significant funding and programmatic development. It seems to be bigger today than it was yesterday. So, what are the factors that drive this crisis? And I'll highlight 6 of them for you. Obviously, if there's overrepresentation in our jails, more people with mental illness need to be arrested. A couple big factors associated with that: substance use disorders. And that steep slope that I showed you on the slides with the overall correctional population, a large part of that is due to our approach to drugs and drug sanctioning and drug sentencing, okay? If I have a mental illness, serious mental illness, I have 3 times the likelihood of having a co-occurring substance use disorder. And if we have policy and programs that are arresting and bringing individuals with substance use disorders into our facilities, then differentially you're going to bring more people with mental illness. A second contributing factor to these high arrest rates is homelessness, a chronic national tragedy that has been present for decades. There are 2 million individuals this year that won't have an adequate place to stay. A homeless individual is a very visible individual in our community, frequently drawing the attention of law enforcement, that oftentimes will make arrests, sometimes for misdemeanor offenses, but in a way that brings in a population that also has high percentage of behavioral disorders. So about 40 to 50% of our homeless populations with alcohol use disorder, about 10 to 20% with drug use disorder, about 25% with serious mental illness. So our homeless policies and the way in which we approach homelessness and our lack of affordable housing, a session that we will have later on in this conference, has a large impact on the number of individuals with mental illness coming through the door. Once in the door, as I highlighted earlier, those individuals with serious mental illness stay longer, same charges, controlled for demographics, both in pretrial status and sentenced. Pretrial, an interesting phenomena where individuals wait adjudication on their charges. And we have learned from recent research that even small time in jail can mess up your life. Don't make your job, don't get paid, don't pay your rent, end up on the street. People that spend time in pretrial take pleas more often, are sentenced more often, and have longer sentences than those that don't. So, in our study in New York, individuals with mental illness, 80 days length of stay on average compared to those without 40 days. Longer stays. The same holds true in our prison. The last Bureau of Justice Statistics study showed that individuals with mental illness controlled for charges and sentences stayed 15 months longer than those without. They don't do well within these settings, those individuals with mental illness. They're frequently targets of aggression. They do get in fights. They spend more time in administrative segregation. Parole boards are reluctant to send them back out with some concern about violence, which may be ill-placed, but nonetheless are associated with long lengths of stay. We also know that there is limited access to health care, generally, okay? And that with the Affordable Care Act and the expansion within Medi-Cal, there have been millions of people that have gained a ticket to the theater, is the euphemism we use, that allows them to get seen. A very important development. Healthcare, well, I'll talk about later, necessary but not necessarily sufficient, is an important stabilizing factor for individuals in their community. And we're all watching with concern the next administration and what ACA turns to, but I'm confident that California will continue its commitment to expanding as possible access to care in community. We also know that individuals with mental illness come back more often than those without. The judges in the audience can affirm this. The revolving door that they see, that same person before them, time after time after time, that get arrested, release, and arrested again. A study that Dr. Jen Scheme conducted suggested that individuals with mental illness, while they come back more often, do so not necessarily for new arrests and new charges, but often for violating the conditions of their release, technical violations. This gives us an opportunity to think about, are there alternatives for those individuals that don't pose a risk to public safety, some other place besides jail that they may return to? We have a wonderful science in behavioral health, and that we have evidence-based practices that we know, when applied with fidelity to the model, produce outcomes of improved public safety and improved public health. However, when you walk through a door in a community mental health center, let's say, you don't often get, or you can't predict that you will, the state-of-the-art evidence-based practices associated with these good outcomes. So that we have a science-to-service gap that we need to figure out how to bridge. And we have a workforce issue that we need to figure out how to solve. And those of you in rural counties can tell me a lot about how scarce it is to find anybody to provide care, let alone a care that reaches the standard of evidence-based practice. And the last factor contributing to the overrepresentation that we're here to discuss is that individuals with serious mental illness have more of the criminogenic risk factors, the same factors that any one of us who have are associated with return to custody. And I want to spend a little time on that. Peterson, Scheme, and colleagues did a study in Minnesota looking at 150 inmates in the county jail who met criteria for schizophrenia or schizophrenia spectrum disorder, and did extensive interviews with them about how they ended up there. Fully 2/3 of them, through that evaluation, wound up in jail, no relationship to the mental illness. All right? They stole something, they hit somebody, they committed a crime. About 1 in 5 had direct or indirect association with their mental health problem. What am I talking about? That individual with bipolar disorder that goes into a hypomanic phase and ends up in a fight that requires arrest and segregation in jail. That individual with schizophrenia who hear voices that say, hit him, and they do, and get arrested for that assault. But the vast majority of individuals with serious mental illness end up in jail for the same reasons than those folks without. And these are called their criminogenic risk factors. And when I talk about criminogenic risk, I'm not talking about the type of crime that they were charged with, whether they're dangerous or violent, whether they will show up in court on the court date or not. Those are very important dimensions, don't get me wrong, and we need to understand them. They will come into play as we think about our release and sentencing options. But when I refer to criminogenic risk and the literature, we're talking about how likely is a person to commit a crime or violate their conditions of supervision and return to custody. That's crim risk. And we can measure crim risk, and there are a variety of tools out there that do that. The tools are all based on the combination of assessing static factors and dynamic factors. Static, I can't do anything about it. I got my criminal history. I've been arrested a lot or not, the number of convictions, the type of offenses, the current charges, the age at first arrest, my current age. I'm more risky if I'm younger than older. My gender, I'm more risky as a man than I am as a woman. These are the static factors that go into our risk scores. More important, I say, are the dynamic factors. more important because they can be changed. And that's what's really important. These are things that, if addressed, can mitigate the likelihood of return. The top 4: history of antisocial behavior, antisocial personality pattern, antisocial thinking, antisocial peers. These are conditions that we need to focus on for those individuals in moderate and higher risk categories. The next central 8: family or marital discord, poor school and work output, few leisure recreational activities, substance use. Again, these are the things that get people in trouble, and these are the factors that we can, through strategic interventions, help change. These factors support the risk-need responsivity model, R&R, in which the risk principle says focus on the higher risk cases if you're going to get the bang out of your public safety buck. The needs principle says focus on those dynamic risk factors which have associated needs that are associated with return to custody. And the responsivity principle talks about our need to recognize not everyone's alike, and they differ in terms of gender, race, ethnicity, language, and we need to accommodate that in the strategies and interventions that we design. If we don't look at risk, we can end up doing harm, a violation of the oath that I took as a physician. In this study by Ed Latessa and colleagues in Ohio, they looked at the community correctional facilities. These are basically halfway houses for people coming out of the Ohio State prison system. And that this study retrospectively looked at the assignment of individuals to halfway houses, which was done prior to the study without any regard to what their risk is. What we see in the results shown here, individuals with moderate and higher risk, they ended up returning to custody less often than if they didn't go into the community facilities. That's a good thing. However, those individuals that were assigned with lower risk, they ended up worse off for all the tax dollars that were spent to provide them that level of care, worse off than if nothing was done, all right? They hung with the wrong people, they learned the wrong skills, they didn't get back into the community and reconnect with people that made a difference in their lives, and in fact did harm. The needs principle is one in which we need to focus on those factors that are associated with return to custody, and that criminal behavior, surrounded by the yellow circle, the big 4, thinking, peers, personality, we can do things about that. When I was in training, these antisocial traits, which rolled up into antisocial personality disorder, I was taught that there's nothing you can do about that they're egosyntonic phenomena, that the person doesn't want to change. And then what did we do? We listed them on Axis 2 in our DSM nomenclature, which allowed us to ignore them, basically. It's not true. People can change with appropriate strategies and interventions. The responsivity principle, as I highlighted earlier, mental illness affects all of the central 8 factors, but mental illness was not one of the central 8 factors, okay? But if I'm depressed and can't sleep and can't get out of bed and I'm hopeless, how good am I going to be as a participant in my Thinking for Change group? Not so good. I probably won't go. I won't show up. I need treatment for my depression, maybe some antidepressant medication to allow me to function at a higher level and engage in care. So mental illness is a responsivity factor, and mental illness treatment is absolutely necessary, but not necessarily sufficient. It in itself will not produce the results that we want. Dr. Skeem says symptoms don't cause crime and treatment doesn't reduce crime. Not by itself, all right? But we want to, and the point of stepping up is to integrate this in some meaningful way. This allowed us to knit together available research in a product that's on your resource list and create a framework in which we suggest we need to understand risk. Where does that individual sit on this risk scale? And then afterwards, what about substance use disorder? 60 to 80% of our population has some degree of substance use disorder, from low severity to high severity. And then lastly, where do we sit in terms of serious mental illness? And with assessing these dimensions, we can then sort people into categories. And I know this gets a little wonky, but I'm only using it to represent those groups on the left side, lower criminogenic risk. It doesn't mean that we don't do anything for them. We have identified behavioral health needs. They need to be linked and connected to care in some meaningful way. On the right side of this chart are those with higher risk. And indeed, that group is where the collaborative strategies between supervision and treatment come into play. So let's spend our criminal justice resources on those individuals with moderate and higher risk. Let's make sure there are sufficient resources for all that need the behavioral health treatment that may be associated with reductions in crime. So why is this so hard to fix? These are challenges that we've taken from several counties that we've worked with. First, being data-driven. We need data to understand how to design solutions. What I have here is a sequential intercept mapping product from Los Angeles County that was done several years ago. Very important tool in the toolbox, understanding where the individuals fit from arrest through release and how programmatically we might address them. And that the problem with this is that it doesn't give us a sense of the scope of the problem. So we may see a large circle in the center about specialty courts, and Lord knows they are effective, but for a small group of participants, 50 or 100 in our court when there are 1,000 or 2,000 defendants with mental illness. So we want to make sure that we have data that allows us to understand the scope of the problem. It is also important that we be data-driven and that we understand the health assessment of both mental health and substance use disorders, and that in doing so, we can characterize that population better. But when we look around the country, that doesn't happen very often in a systematic and reliable way. And that when we did our survey of counties here in California, 25% of the counties talked about universal screening for mental illness happening at their jail. 17% said that it's happening for substance use disorders. 12% said they do it routinely for criminogenic risk. Good, but not good enough. We need to raise those percentages, and we'll be interested in follow-up discussions in how you might do that. Challenge 2 is using best practices. I said earlier that we need to develop strategies and implement programs that address the core needs of the population. And those programs exist, and they are out there. And you'll hear in a breakout later on about a new cognitive behavioral treatment intervention that's being tested in Sonoma County to address the CRIM needs of a population with serious mental illness. If we get the risk results, it's not sufficient unless we apply the results. So on the left, assigning people to programs independent of risk, as the Ohio example. On the right, stratifying individuals into low, medium, and higher risk categories so we can get the bang for the buck. Challenge 2 is using best practices. They're out there. There probably isn't a term other than evidence-based practice that got so fuzzy so quick. We're all doing them, right? But there are specific EBPs to address the factors that are associated with return to prison. In this slide, I highlight integrated treatment. In the survey that's done by SAMHSA every year, respondents with co-occurring disorders talked about the care that they got. 40% of them got no care in the previous 12 months. 45% of them got some care, but it was only mental health care, when the evidence-based practice for co-occurring disorder is integrated care. So we need to identify and expand that particular process. It is important as a challenge to think about all that $83 billion that we spend bringing people into our jails and prisons, screening, assessment, and providing treatment, and yet we then send them out without a connection to care. In this study in Franklin County, Columbus, Ohio, there were 1,700 people that came out of the jail in 1 year that was known to the system prior to arrest of having serious mental illness, that when we followed 12 months later, had no contact with the behavioral health system. Knew them before they went in. I don't think they got cured while they were there. Didn't get connected on release. We need to understand and do that better. And lastly, as a challenge, is tracking progress. We collect lots of data, but it doesn't often inform policies. So that we would like our Board of Supervisors to be asking questions about these metrics. Are there fewer people being brought to jail? Does law enforcement have alternatives to incarceration working with a comprehensive crisis response system? When they get to jail, can we shorten their length of stay so they look more like general population data than those with serious mental illness? Can we increase the percentage of individuals in jail that are connected to the right supports? And lastly, once out, can we provide them the supports and treatment they need in the community so they don't come back and lower recidivism? So how do we move forward? And I think I've saved about 90 seconds for this section. You know, it's pretty simple, basically, you know. It's very complicated, and all of you have been working on this for a while. We are about to release a document, 6 questions. It's in your folders. 6 questions that we think the county leadership should ask about whether you have the elements of a plan. And this is going to be the focus of our plenary that's coming up, and that we'll go into it in detail. Committed leadership, your leaders are here. Your leaders have passed resolutions. Your leaders are committed, all right? And that, do they share a vision, we hope? Is there a person in charge that can help us be accountable for the results within that community? Do you have timely screening and assessment? I already shared the survey results. Not a lot of counties are doing that. Do you have baseline data? How many people in your jail today meet criteria for serious mental illness? How are we going to know if the policies and programs that we want to implement make a difference if we don't know the baseline? I just showed you lots of good work in New York, but the number of people in jails went up, not down. Have you conducted a comprehensive process analysis and service inventory? Do you know where the gaps are that are out there within your systems of care? One of the gaps identified by our survey was that needed to have ability to track progress, and that there was a wish from the respondents, the 124 respondents, that there were more resources to help gather data, analyze data, and track data. So these are the issues that you're going to be talking about over the next several days. There are opportunities out there. At the federal level, as Michael shared with you, President Obama signed the 21st Century Cures Act, reauthorizes the federal MyOCRA program. I know you have your state MyOCRA program over time here in California, expands diversion opportunity, expands training for law enforcement, prioritizes federal grant funding for evidence-based programs, use of risk assessment, and a focus on data-driven decision. And there are California opportunities. All 3 branches have, over time, suggested ways. In 2011, the Judicial Task Force, 137 recommendations, all on target with what I'm talking about. 2015, an implementation plan, all in service of moving our system towards the goal of reducing prevalence. So I'll end this quick tour across the behavioral health, criminal justice landscape with a reminder that behind each of the stats I've shared, the graphs I've shown, the stick figures that have been up on the slide, are real people, our citizens, our mothers, fathers, sons, sisters, brothers. And they have their own aspirations and goals, and their families care that they reach them as well. Tomorrow, we'll have a plenary that has the voices of family and consumers there. Our work can and must make a difference in their lives. I'll end with this quote from Dr. Francis Peabody, who gave this at the Harvard Medical School commencement in 1926. One of the essential qualities of the clinician, and let's substitute and add judge, sheriff, probation chief, is interest in humanity. For the secret of care of the patient, and let's substitute defendant, inmate, probationer, is in caring for them. Thanks to all of you for caring, and I look forward to the next day and a half.